So let's start. So first of all, talking about appendix, I hope all of you are quite aware that appendix or vermiform appendix, like it is called as, it is a vestigial organ, right? And it is at the junction of the small intestine and the large intestine. That is your ileum and cecum, right? So it is a tubular structure, and appendix can get obstructed, okay? And the most common cause of obstruction is usually fecolids. And if the neck or the mouth of the appendix get obstructed, there would be a high chance of bacterial overgrowth in that place, and that can lead to appendicitis in this patient. Appendicitis is a very common emergency in surgery, general surgery. Okay, important it is. So please let me know for appendix usually, what is the most common position of appendix? The most common position of appendix would be, very good. The most common position of appendix is retrocecal. Most common position of appendix is retrocecal. Whereas the whereas the least common position would be, so the most common position of appendix is retrocecal, that is behind the cecum, followed by pelvic. Second most common is pelvic position, whereas the least common one is post-ileal. Please remember, the least common one is post-ileal. Least common one is post-ileal. Important. ठीक है, याद रखना. Now, if I talk about appendix, can anybody tell me which is the most consistent sign of appendicitis? Which is the most consistent sign of appendicitis? The most consistent sign of appendicitis. As I already told you, the most common cause of appendicitis would be fecolid obstruction. Most common cause is usually a fecolid obstruction. Important, right? What is the most consistent sign? No, pain is not the most consistent sign. Please remember, okay? Fever is also not the most consistent sign. So fever, nausea, vomiting, pain in the right, pain usually in the right iliac fossa at the McBurney's point, and this pain would be referred to the umbilicus, okay? So all of these would be seen, but those are not the consistent sign. The most consistent sign is loss of appetite, and that is what is called as anorexia. The most consistent sign would be loss of appetite or anorexia. That is important to be remembered, okay? It is the anorexia which is the most consistent sign in cases of appendicitis. All other features are definitely seen, like fever, pain in the right iliac fossa, and this pain in the right iliac fossa will also radiate to the umbilicus, and it is due to the same dermatome or the same nerve innervation. Which is the nerve innervation? Anybody? The segment which innervates the appendix as well as the umbilicus, and therefore we can see a referred pain from the appendix to the umbilicus. Which segment? Anybody? Which nerve segment? So please remember, it is T10. Okay, it is the T10 nerve segment. It is the T10 nerve segment. Important to yaad rakhna. Then if I talk about appendicitis, usually it is more common in young child or it is more common in adolescents. Okay, so you can remember, it is more common in either children or it is more common in adolescents. Okay, so more common in children or adolescent age group, right? Important hai, yaad rakh lo. Now please tell me, what is the investigation of choice for adults and what is the investigation of choice for children? In cases of acute appendicitis, what is the investigation of choice for adults? Anybody? The investigation of choice for adults would be, the investigation of choice for adults would be, for children it is ultrasound. Very good. For children it is ultrasound abdomen. Okay, for children it is ultrasound abdomen. Very good. For adults, Pooja, it is CECT abdomen. For adults it is CECT abdomen, right? But initial investigation would always remain an ultrasound abdomen, followed by CECT abdomen in adults also. Okay, so the first line is always ultrasound, but in children usually we prefer doing a ultrasound only. If I talk about the clinical scoring system that we have for appendicitis, that is what is called as your Mantel scoring system. That is what is called as your Mantel scoring system, which is the mnemonic in itself. It is also known as the modified Alvarado score. It is also known as the modified Alvarado score. So yaad rakhna, Mantel scoring system is also called as modified Alvarado score, where M stands for a migratory right iliac fossa pain. M stands for the migratory right iliac fossa pain. A stands for the most consistent sign, and that is anorexia. A stands for the most consistent sign, that is anorexia. N stands for nausea and vomiting. N for nausea and vomiting. T stands for tenderness in the right lower quadrant. T for tenderness. Tenderness means on palpation, if there is pain, that is what is called as tenderness. So when you palpate the right iliac fossa, then there would be pain. That is what is tenderness. Okay. R goes for rebound pen or rebound tenderness. Okay, R goes for rebound tenderness. What do we mean by rebound tenderness? As you can see in the image given below, here you palpate the right iliac fossa, you press it, and as soon as you release it, there would be pain. Okay, and that is what is called as rebound tenderness. E goes for elevated temperature, that means fever. L goes for leukocytosis, that means the WBC count in CBC would be elevated. And lastly, S goes for the shift of WBCs towards the left. That means which cells would be predominant, which WBCs are predominantly increased, as it is an acute infection. So which WBCs would be predominantly increased? Please let me know. Okay. So out of these, everything has a score of 1 except for L and T. Okay, everything has a score of 1 except for LT. That means leukocytosis and tenderness has a score of 2. Leukocytosis and tenderness will have a score of 2. Therefore, the total would be 10. Okay, so the total Mantrel score would be 10, or total modified Alvarado score would be 10. If the score is less than 5, then the appendicitis is very unlikely. If the score is between 5 to 6, then appendicitis is possible. But if score is more than 7, okay, if the score is more than 7, then there is a high probability or high possibility that the patient would be suffering from acute appendicitis. Okay, likely appendicitis hoga if the score is more than equal to 7. Important. No issues with this. Yaad rakh lo. So very good. Neutrophils. Okay, please remember, neutrophils would be elevated usually in cases of acute infections, and that is what is meant by the shift of WBCs towards the left. That means there would be a predominant neutrophilia in the patient. ठीक है, कोई दिक्कत नहीं है. Please remember this. Now, if I talk about the treatment, what is the management in cases of acute appendicitis? What is the management? Definitely, you need to keep the patient nil per oral. Right, you need to keep the patient nil per oral. You need to give IV fluids to the patient. You need to give IV antibiotics to the patient. You will give analgesics to the patient for pain relief. Okay, but the definitive management would be, the definitive management of acute appendicitis is always and always the definitive management. Very good. It is appendicectomy. Please remember, whoever is starting to do this again and again, I would request you, you can leave it right now, because I'm not in a mood at all to actually have this disturbances in between the classes. ठीक है? So अगर पढ़ना नहीं चाहते हो, you can leave at this point itself. ठीक है? So the definitive management is definitely appendicectomy. That means removal of your appendix. So in cases of acute appendicitis, because why you need to do an emergency appendicectomy? Because there is a high chance of perforation. And if the appendix perforates, then there would be a high chance of peritonitis in the patient, right? And peritonitis is a deadly condition, right? Now, please let me know, in cases of, if the appendix perforates or any of the bowel perforates and there is peritonitis, what is the appearance seen on abdominal X-ray? One liner hai, what is the appearance seen on abdominal X-ray in cases of peritonitis, generalized peritonitis? Please let me know that. So here, as I told you, it is appendicectomy. Please remember, it depends whether we can do a laparoscopic appendicectomy, okay, or a open appendicectomy. Usually, if it is an emergency condition, we prefer doing an open appendicectomy. Yaad rakhna, in cases of emergency, we don't go for laparoscopic appendicectomy. Rather, we prefer doing a open appendicectomy, because the complications are much lesser as compared to the laparoscopic appendicectomy. In cases of elective or interval appendicectomy, definitely we can prefer a laparoscopic one. But usually, in cases of emergency, we prefer doing a open appendicectomy. Cupula sign would be seen, but it is a sign of pneumoperitoneum. I am asking you about generalized peritonitis. Generalized peritonitis may we see a soap bubble appearance. Please remember, we see a soap bubble appearance in cases of abdominal X-ray. Okay, in which condition? In cases of generalized peritonitis. Yaad rakhna. So if I talk about open appendicectomy, which kind of incision is given? Usually we will give incision in the right iliac fossa, and this incision which is given in the right iliac fossa, it is called as the McBurney's incision. It is called as the McBurney's incision. So I hope all of you are quite aware that if this is the abdomen, over here from 2/3 from the umbilicus and 1/3 from the anterior superior iliac spine, we have the McBurney's point, and this McBurney's point is a surgical landmark for appendix. Okay, McBurney's point is the surgical landmark for appendix. So here if you give the incision, this is what is called as your McBurney's incision. So McBurney's incision can be a muscle splitting incision or a muscle cutting incision. So muscle splitting McBurney's incision is called as gridiron incision. Muscle splitting McBurney's incision is called as gridiron incision. Muscle splitting McBurney's incision is called as gridiron incision, whereas muscle cutting one is called as Rutherford-Morrison incision. Okay, muscle cutting one is called as Rutherford-Morrison incision. No issues with this, anybody? Yaad rakhna. Apart from that, in cases of elective appendicectomy, we can give a transverse cut as well. Okay, in cases of elective appendicectomy, we can give a transverse incision, and that transverse incision is called as anybody. The transverse incision which is given in cases of elective appendicectomy, it is called as the Lanz incision. Very good. It is called as the Lanz incision. But in cases of elective appendicectomy or interval appendicectomy, usually we prefer doing a laparoscopic surgeries nowadays. Okay? Yaad rakhna. No issues with this. I hope so. Now, if I talk about the clinical examination, we have spoken about the treatment. So, if I talk about the clinical examination, yes, laparoscopically better, cosmetically better hota hai laparoscopy. If I talk about the different signs which are seen, clinical signs which can be elicited. So if you press the right iliac fossa, if you palpate the right iliac fossa and there is pain, this is what is called as the McBurney's sign. This is called as the McBurney's sign. Okay, pain on pressing the McBurney's point is called as the McBurney's sign. Then pain on pressing the left iliac fossa. If you palpate the left iliac fossa, but the pain is in the right iliac fossa, this is what is called as the Rovsing sign. Okay. You palpate the left iliac fossa, but pain is in the right iliac fossa. This is what is called as the Rovsing sign. This is what is called as the Rovsing sign. Yaad rakhna. And it is usually seen in which position of appendix? It is usually positive in paracecal position of appendix. It is positive in paracecal position of appendix. Next, if I say the patient's leg was flexed, okay, the lower limb was flexed and internally rotated, and then there is pain. This is what is called as the obturator sign. Okay, the leg is flexed and there is internal rotation which is done, and then there is pain in the right iliac fossa. That is what is called as your obturator sign. That is called as your obturator sign, and it is positive when the appendix is pelvic in location. Okay, it is positive usually in cases of pelvic appendix. Next, if I talk about the psoas sign, when you hyperextend the lower limb, and there is pain in the right iliac fossa, that is what is called as your psoas sign. That is what is called as your psoas sign. Important, yaad rakhna. Okay, no issues with this. And psoas sign is usually positive in cases of post-cecal or retrocecal. Okay, so psoas sign is usually positive in cases of retrocecal appendix. Okay, psoas sign is usually positive in cases of retrocecal appendix. Ye questions wo definitely पूछ सकते हैं, याद रखना. And when you press the right iliac fossa and suddenly release it, and there is the peritoneum sets in vibration, and that causes rebound tenderness. This rebound tenderness is known as which sign, anybody? This rebound tenderness is known as, jaldi se naam batao. This rebound tenderness is known as, important hai ye. This rebound tenderness is known as the Dumfries sign. Is on pain on cuffing. If the patient cuffs and there is pain, that is what is a Dumfries sign. It is not rebound tenderness. Yaad rakhna. Very good. Blumberg sign. It is known as the Blumberg sign. So rebound tenderness is known as the Blumberg sign. Rebound tenderness is known as the Blumberg sign. Yaad rakhna. No issues with this, anybody? Now, a question from December. Okay. It says a pregnant female, irrespective of her gestational age, okay, irrespective of her pregnancy, kitne weeks ki hai, kitne weeks ki nahi hai. A pregnant female presents with appendicitis, acute appendicitis. What is the management? What would be your management? You will just treat the patient conservatively, or you will plan the patient for elective appendicectomy in the second trimester or after delivery, or you will do emergency appendicectomy in the patient. Very good. Please remember the management, because please remember in cases of pregnancy, already it is immunocompromised condition and there is a high chance of perforation or rupture of the appendix. Therefore, in cases of pregnancy, if a patient presents you with acute appendicitis, the management is always emergency appendicectomy. The management is always emergency appendicectomy. Management is emergency appendicectomy. Yaad rakhna. Okay, no issues with this. Now, if there is a patient of appendicitis and he did not present to you in the earlier stages, now he presents to you, and when you palpate the appendix or the right iliac fossa, there is a lump which is felt. Okay, it is due to the omentum which wraps around the, okay, the omentum or the mesentery wraps around the appendix, and that forms this appendicular lump. What is the treatment of choice or the management of choice in cases of appendicular lump, anybody? The management or the treatment of choice in cases of appendicular lump, when you can feel a lump in the right iliac fossa. Usually it is a sequel or complication of appendicitis. Very good. It is a conservative regime. This is a conservative regime known as the Ochsner-Sherrin regime. It is the conservative regime known as the Ochsner-Sherrin regime. Which regime? Ochsner-Sherrin regime. Which regime? Ochsner-Sherrin regime. It is a conservative management for which condition? It is a conservative management for appendicular lump. Here you will only keep the patient nil per oral. You will give IV fluids, IV antibiotics to the patient. Okay, analgesia if there is pain. Okay, and then you discharge the patient. Okay, you discharge the patient after the patient's condition improves, and then you call the patient for interval appendicectomy. Then you call the patient for interval appendicectomy. That means after 6 weeks, 6 हफ्ते के बाद, you will call the patient for interval appendicectomy. No issues with this. याद रखना, if they ask you it is appendicular lump, the treatment of choice would be a conservative regime known as Ochsner-Sherian regime. Okay, please remember, if the patient recovers, definitely by Ochsner-Sherian regime, you need to discharge the patient and call them for interval appendicectomy. Call them for interval appendicectomy. And interval appendicectomy is performed after 6 weeks. After 6 weeks, याद रखना, कोई भी interval surgery जो करोगे, it is performed after 6 weeks usually. Okay, if the patient does not recover, in this condition you need to perform a emergency appendectomy. Okay, if the patient does not recover, if his condition is deteriorating, pain increase हो रहा है, fever बढ़ रहा है, all of these, then definitely you need to perform a emergency appendicectomy in this condition. And if there is appendicular abscess, then definitely the treatment of choice would be a percutaneous incision and drainage. Okay, the treatment of choice would be a percutaneous drainage of the appendicular abscess. No issues with this, anybody? I hope appendix was done. अगर कोई भी दिक्कत हो, please let me know. Then if I talk about a retroperitoneal organ, and that is what is your pancreas. So please remember, if they ask you the location of pancreas, so pancreas are usually retroperitoneal in location. Okay, pancreas are retroperitoneal, behind the peritoneum. Okay, so pancreas is important because if there is pancreatitis in a patient, definitely it is again a very important, then again it is a surgical emergency. You need to treat it there itself. Okay. Now please let me know, first of all, if I talk about pancreas, as we know, it is a it has an endocrine as well as an exocrine function, right? Which is the most common congenital anomaly of pancreas? The most common congenital anomaly of pancreas would be annular is not so much common. Okay, annular is not so much common. Please remember, pancreas usually develop from two buds, a ventral pancreatic bud and a dorsal pancreatic bud. Okay, if these two buds do not fuse with each other, that is what is the most common congenital anomaly of pancreas, and which is known as pancreas divisum. That is known as pancreas divisum. Please remember, if the ventral and dorsal pancreatic bud does not fuse with each other, that is called as pancreas divisum, and pancreas divisum is the most common congenital anomaly of pancreas. Okay, if the patient is asymptomatic, you do not need to treat the patient. If the patient is symptomatic only, then you do a repair in this condition. Okay, no issues with this. Please remember this. Whereas if I talk about annular pancreas, as I told you, so annular pancreas is due to malrotation of the ventral pancreatic bud. Okay, malrotation of the ventral pancreatic bud, and therefore a pancreatic tissue, it forms a ring-like structure around the duodenum. Okay, a pancreatic tissue will form a ring-like structure around the duodenum and it will compress the duodenum. Okay, so annular pancreas will lead to which sign on X-ray? Anybody? Which abdominal on abdominal X-ray, which sign is seen in cases of annular pancreas? It is a differential diagnosis. Important. Please let me know, annular pancreas, when it forms a ring-like structure around the duodenum. Very good. It is the double bubble sign. So it is a differential diagnosis to duodenal atresia. So please remember, annular pancreas, Lad's band, and duodenal atresia, all these three conditions on abdominal X-ray will show a double bubble sign. Okay, double bubble sign. Now, a male patient presents to you. A male patient presents to the emergency room with sudden onset, severe acute epigastric pain and which radiates on lying supine. This is the classical finding. Please remember, अगर ऐसा कोई case आता है, this is the classical finding of acute pancreatitis. याद रखना. Okay, a male patient presenting to you in the ER, sudden onset, severe, or sometimes they will refer it to as the excruciating pain. Okay, so sudden onset, severe or excruciating acute epigastric pain or abdominal pain, and which radiates to the back. Okay, which radiates to the back, and this pain usually increases on lying supine. Okay, this pain usually increases on lying supine, whereas it is relieved on bending forward. Okay, it is relieved on bending forward because the pancreas will not come in contact with the peritoneum. Okay, so please the pancreas will not come in contact with the muscles. Okay, and therefore the pain would be relieved. So it is increased on lying supine and it is decreased on bending forward. So usually the patient would be sitting in this position, in a tripod position, bending forward. This is the classical sign. Now please let me know, कल हमने एक चीज डिस्कस की थी, a patient presenting to you with chest pain which is radiating to back or which is radiating to the interscapular area. What was that condition? Okay, what was that condition? Abdominal pain radiating to back, definitely pancreatitis. But chest pain radiating to back, anybody? Please let me know. Chest pain radiating to back, yesterday we discussed. Here also the patient will have nausea and vomiting definitely. Very good, all of you. Aortic dissection. Please remember it is aortic dissection when the chest pain is radiating to the interscapular area or to the back. याद रखना. So here coming back to our question, patient ER में आता है sudden onset severe or excruciating acute epigastric pain radiating to back, increases on lying supine and relieved on bending forward, nausea, vomiting, fever. All of these features are present. What is the next best step, anybody? So now you're definitely suspecting pancreatitis. You have performed a per abdominal examination, all of that. What is the next best step to be done? What is the most specific test to be done for acute pancreatitis? So here the provisional diagnosis that you are thinking of is definitely acute pancreatitis. Okay, it is definitely acute pancreatitis. What is the next best step, anybody? Very good. It is the next best step would be checking for the pancreatic enzyme levels. And the most specific test, if they ask you, okay, if they ask you the most specific test for pancreatitis, the most specific test or the most sensitive test, the answer remains same. The most specific and the most sensitive test for acute pancreatitis is serum lipase. It is serum lipase. You definitely also can check for serum amylase levels. Okay, you can also check for serum amylase levels, please remember, but serum amylase is very non-specific, and therefore the most specific or the most sensitive test is definitely serum lipase. These levels would be elevated in a patient. Okay, no issues with this. Yaad rakhna. What is the investigation of choice, anybody? So definitely we have performed a serum amylase and serum lipase. What is the investigation of choice to confirm our diagnosis? No, trypsinogen se better. Trypsinogen is not elevated in all conditions. So it is better serum lipase is the best one to be answered. So the MRCP acute pancreatitis mein hai patient. Okay, so please remember acute pancreatitis mein hai patient, chronic mein nahi hai. So here the investigation of choice should first of all be non-invasive and jaldi hona chahiye. That is a CECT abdomen. Please remember the investigation of choice would be a CECT abdomen. Investigation of choice is a CECT abdomen. And if I talk about the CECT abdomen, as you can see over here, okay, this is a case of hemorrhagic acute pancreatitis. ऐसी image आ चुकी है एक बार. So the pancreas is almost damaged. Okay, it is ruptured almost, and this there is accumulation of blood that you can see. The hypoechoic, the black color area, it is due to accumulation of blood around the pancreas. So this is a CECT abdomen which is performed, and here you can see a case of acute hemorrhagic pancreatitis. Okay, this is a case of acute hemorrhagic pancreatitis. ऐसा कोई आता है at the level of pancreas, please remember, okay, to rule out acute hemorrhagic pancreatitis in this condition. Okay, and if I talk about the X-ray, okay, if I talk about the abdominal X-ray or a chest X-ray of this patient, whatever you take, okay, so in X-ray, what would be the sign seen? Please let me know what is the sign seen. Here you can see that the colon is like the continuity of the colon is not present. Okay, the continuity of colon is not seen. It is because the inflamed pancreas. It is because of the inflamed pancreas. Very good. It is known as the colon cutoff sign. This is known as the colon cutoff sign. This is known as the colon cutoff sign. This is known as the colon cutoff sign. Okay, please remember. Sometimes we can also see the sentinel loop sign. Okay, we can also see the sentinel loop sign or the colon cutoff sign. This is important. Please remember this. No issues with this, anybody? Now, please tell me the criteria. There are multiple criteria, but the important one to assess the patient of acute pancreatitis, on which criteria or which scoring system we assess the severity of pancreatitis. Naam batao, important hai naam. On which criteria or on which severity scoring system? Very good. It is the Ranson scoring system. It is the Ranson scoring system. Okay, so severity of pancreas is assessed with the help of which scoring system? It is assessed with the help of the Ranson's criteria or the Ranson scoring system. Okay, it is assessed with the help of Ranson's criteria or the Ranson scoring system. Okay, please remember this. Okay, they would not ask you all the things about Ranson's, but at least you need to remember the name of Ranson's. ठीक है, याद रख लेना. Apart from this, definitely we also have for any other condition, for any other emergency condition, for a chronic health condition, we have a score called as Apache. We also have a score called as Apache. Please remember, acute physiological and chronic health evaluation. So yaad rakhna, for any chronic illness, if they ask you which score can be used, it is the Apache score. It is the Apache score. And please remember, which is the CT severity index. Like for usually your COVID, we have CORADs, right? So just like that, in cases of pancreatitis, the CT severity index is assessed by which score? Very good. It is the Balthazar score. Okay, the CT severity index is given by the Balthazar scoring system. Okay, the CT severity index is given by the Balthazar scoring system. What is the management in cases of acute pancreatitis? Please let me know what is the most common cause of acute pancreatitis. First of all, what is the most common cause of acute pancreatitis? Important hai. What is the most common cause of acute pancreatitis? Very good. The most common cause of acute pancreatitis is gallstones. So the gallstones will obstruct the opening of the biliary ducts or the pancreatic duct, and therefore it can cause inflammation of the pancreas. So the most common cause of acute pancreatitis is gallstones, followed by alcohol. Followed by alcohol. Important. Yaad rakhna. ठीक है? Now please remember, what is the management? So if a patient of acute pancreatitis comes to you in emergency, definitely you need to treat the patient first of all conservatively. ठीक है? So if there is no risk of hemorrhage वगैरह, okay, then you need to treat the patient conservatively, and that should be, you need to keep the patient nil per oral. You need to keep the patient nil per oral, and you should start IV fluids to the patient. You should start IV fluids. You will give IV antibiotics to the patient, and definitely if there is pain, IV analgesia can also be given. IV analgesics, which is the most preferred antibiotic or the best antibiotic used for acute pancreatitis? Anybody? So yes, fluid would usually be ringer lactate. In any chronic condition like burns ho gaya, pancreatitis ho gaya, the preferred fluid, the most isotonic fluid, if they ask you, definitely it is ringer lactate. Okay? So for the most preferred antibiotic is usually meropenem. Please remember, the most preferred antibiotic is meropenem is started in this patient. Okay, a broad spectrum antibiotic is usually given. Okay, yaad rakh lena. And if the patient presents to you with acute hemorrhagic pancreatitis, that means now there is hemorrhage in the retroperitoneum or hemorrhage in the peritoneum, then it can also present to you with these two signs. Okay, and what are these signs suggestive of? These signs are suggestive of hemoperitoneum. The first one shows you discoloration around the umbilicus. The discoloration around umbilicus is known as the Cullen sign. Very good. Discoloration around the umbilicus is known as the Cullen sign. Discoloration around umbilicus is known as the Cullen sign. Whereas discoloration in the flanks is known as the flanks. कैसे देखते हो? Turn करने पे, therefore a discoloration in the flanks is known as the Gray Turner sign. Okay, discoloration in flanks is known as the Gray Turner sign. Anybody? Discoloration in the inguinal region is called as discoloration, bleeding or discoloration in the inguinal region is called as periumbilical Cullen sign. Flanks mein Gray Turner sign. In the inguinal region it is called as the, very good AFMG, it is the Fox sign. Okay, it is known as the Fox sign in the inguinal region. Fox sign in the inguinal region. I hope it is clear to everybody. ठीक है, इतना याद रखना important है for acute pancreatitis. Now if I move further to chronic pancreatitis, guys, chronic pancreatitis, the most common cause of chronic pancreatitis, anybody? The most common cause of chronic pancreatitis. So usually the etiological classification for chronic pancreatitis which is given, very good, the most common cause of chronic pancreatitis is alcohol. Most common cause of chronic pancreatitis is usually alcohol intake for a long period of time. And the classification which is given, the etiological classification for chronic pancreatitis, okay, with the help of this etiological classification you can know the causes of chronic pancreatitis, and that is what is called as the Tagar-O classification. That is called as the Tagar-O classification. IV antibiotics, yes, if there is abscess formation, high grade fever, if the patient is not responding to your therapy, then definitely you need to start IV antibiotics. Okay? So, but nowadays definitely acute pancreatitis mein risk of infection is higher, so we can start IV antibiotics early in the course as well. Okay? So it is the Tagar-O classification, which is the etiological classification for chronic pancreatitis, where T goes for toxins, and the most common toxin responsible, as we discussed, it is alcohol. Okay, I goes for idiopathic. I goes for idiopathic. G goes for the genetic factors. G for genetic factors. A for autoimmune causes. A for autoimmune causes. R for recurrent causes. R for recurrent causes, and O lastly for obstructive causes. O lastly goes for the obstructive causes. So the classification used for chronic pancreatitis is known as Tagar-O classification. Important hai, yaad rakhna. No issues with this. Now definitely if the patient is having pancreatitis, the pancreas would not work, and if there is a pancreatic dysfunction, both the functions of pancreas would be functions of the pancreas would not be there. First is the exocrine, second is endocrine function. Exocrine function is what? Secretion of pancreatic enzymes. Okay, exocrine function is secretion of pancreatic enzymes. So if pancreatic enzymes are not secreted, definitely digestion would be affected, and the patient can suffer from malabsorption. The patient can suffer from malabsorption. Along with that, pancreatic enzymes are usually responsible for fat absorption. So if pancreatic enzymes are not there, then definitely the patient will have excretion of fat in stools, and that is what is called as foul smelling, greasy, bulky stools. And this foul smelling, greasy, very good creation, it is steatorrhea. Okay, that is called as steatorrhea. Last time there was a question. Okay, so pancreatitis can also cause malabsorption along with steatorrhea in the patient. Okay, endocrine dysfunction, definitely the main function of pancreas is insulin secretion, right? If the pancreas are damaged, definitely there would be deficiency of insulin. And if there is deficiency of insulin, the patient will develop diabetes mellitus. The patient will develop diabetes mellitus. So for both these conditions, if the patient is having hyperglycemia, then definitely you need to start the patient on insulin or oral hypoglycemic agent. You need to start the patient on insulin or oral hypoglycemic agent. And as the patient is having malabsorption or steatorrhea, you need to give you need to give pancreatic enzyme supplementation. You need to give pancreatic enzyme supplementation. ठीक है? From outside you will give pancreatic enzymes to the patient. No issues with this, anybody? याद रखना. Now, what is the investigation of choice for chronic pancreatitis? ज्यादा नहीं हुआ है, appendix खत्म किया है बस. Investigation of choice for chronic pancreatitis. अभी बताओ जल्दी से. The investigation of choice for chronic pancreatitis. Anybody? The investigation of choice for chronic pancreatitis. Very good. It is MRCP. Why MRCP? Because it is a non-invasive test. Okay. It is MRCP because it is a non-invasive test. Okay. The investigation of choice for chronic pancreatitis is usually MRCP. ठीक है, याद रखना. Most of the books also call it as CECT abdomen. Okay. Most of the books also call it as CECT abdomen. याद रखना. So MRCP. Why? Because on MRCP you will be able to see this kind of appearance. CECT is also done if the patient is in emergency. याद रखना. If the patient presents to you in emergency वगैरह, then CECT is definitely preferred because it is a more accessible method to be done. MRCP is not available everywhere. याद रखना, ठीक है? So CECT would be preferred in cases of emergency या low resource settings like India. तो इंडिया में हम usually prefer करते हैं CECT abdomen. ठीक है? Outside India, definitely MRCP is the guideline. Recommended one is definitely MRCP. So CECT abdomen करेंगे. On CECT abdomen or on MRCP. In cases of chronic pancreatitis, you can see this kind of appearance. What is this kind of appearance called as? So here you can see somewhat calcification. Okay, here you can see somewhat calcification, but usually on a MRCP, you will see dilatation of the pancreatic duct. And this dilatation of pancreatic duct is known as chain of lake appearance. Very good. Dilatation of pancreatic duct is known as the chain of lake appearance. Dilatation of pancreatic duct is known as the chain of lake appearance. ठीक है, याद रखना. So chain of lake appearance is seen in cases of chronic pancreatitis. Chain of lake appearance is seen in cases of chronic pancreatitis. ठीक है, double duct sign भी दिख सकती है. Usually on CECT you can also find a double duct sign. Okay, whereas on MRCP or ERCP you will get a chain of lake appearance. Chain of lake appearance. ठीक है, no issues with this, anybody? What is the gold standard investigation? The gold standard investigation would be gold standard investigation, which is diagnostic as well as therapeutic. ऐसा कौन सा investigation होता है? So the gold standard investigation would be ERCP. Please remember, the gold standard investigation would be ERCP, not ultrasound. The gold standard investigation would be ERCP. Please remember, endoscopic retrograde cholangiopancreatography. ठीक है? I will show you what ERCP looks like because image आई थी ये investigation कौन सी, and that was ERCP. ठीक है? Then if I talk about the treatment of chronic pancreatitis, there can be a draining procedure or it can be a resective procedure. ठीक है? So draining procedure when there is accumulation of fluid या फिर abscess वगैरह है, in this condition usually a draining procedure is done. If the main pancreatic duct is dilated less than 6 millimeter, okay? If the diameter of the main pancreatic duct is less than 6 millimeter, then what should be done? As I told you, ERCP क्यों gold standard है? Because it is diagnostic as well as therapeutic, right? So here I will perform ERCP with sphincterotomy. I will perform ERCP with sphincterotomy. ERCP with sphincterotomy. Okay, please remember what is the treatment of choice if the main pancreatic duct is less than 6 mm. It is usually ERCP with sphincterotomy. It is ERCP with sphincterotomy. You will open up the sphincter properly. You will open up the opening of the main pancreatic duct, and that will relieve the condition of the patient. ठीक है? If the main pancreatic duct is dilated more than 6 mm, okay, if the main pancreatic duct is dilated more than 6 mm, then treatment of choice would either be a Purstow's operation. Okay, it is called as the modified Purstow's operation. It is called as the modified Purstow's operation. So either you can perform a end-to-end pancreatico-jejunostomy. Either you can perform a end-to-end pancreatico-jejunostomy or a side-to-side or a longitudinal pancreatico-jejunostomy. Okay, or a side-to-side or longitudinal pancreatico-jejunostomy. Okay, that is what is done in cases of modified Purstow's operation. Okay, if the head is involved, what is done usually? If the head is involved, what is done? It is known as the beggar's procedure. If the head is involved, it is known as the beggar's procedure. If the head is involved, it is known as the beggar's procedure. That means you will resect the head. Okay? If head is involved, you will resect the head. That is what is known as the beggar's procedure. Whereas if the tail is involved, definitely you can remove the tail of the pancreas easily, and that is what is called as distal pancreatectomy. Okay, that is what is called as distal pancreatectomy. No issues with this, anybody? So if the duct is less than 6 mm, ERCP with sphincterotomy. If the duct is more than 6 mm, Perstow's operation or modified Perstow's operation, that is pancreatico-jejunostomy. If head is involved, Beggar's procedure, removal of the head. If tail is involved, distal pancreatectomy. No issues with this, I hope so. ठीक है, so treatment याद रख लेना chronic pancreatitis की. Then if I talk about external, so if I talk about a complication of chronic pancreatitis, a very important complication of chronic pancreatitis is accumulation of fluid, okay, surrounding the pancreas, accumulation of fluid surrounding the pancreas in a sac-like fashion, and this is what is called as a pseudocyst. This is called as a pseudocyst. Yaad rakhna. Pseudocyst is not symptomatic usually, okay, it would not cause problems to the patient, but if it increases in size, if it is rapidly increasing in size, then definitely the patient can turn symptomatic. There would be pressure symptoms in the patient, okay, pain to rarely dikhega, but there can be pressure symptoms usually in the patient, abdominal fullness वगैरह हो सकता है, okay, so that would be seen. And if there is a pseudocyst, usually it develops 2 to 3 weeks after chronic pancreatitis. Okay, minimum 2 to 3 weeks after chronic pancreatitis episode, the patient will develop pseudocyst, pancreatic pseudocyst. Okay, and it can dilate to a very huge extent. Yaad rakhna. So if pancreatic pseudocyst is developed, what is the treatment of choice? Anybody? What is the treatment of choice? If a patient is having pancreatic pseudocyst, what should be the best management option? What should be the best management option? Or दिख नहीं रहा है क्या? This one is the pseudocyst, guys. This massive dilatation. This one is what is the pseudocyst. So this is a problem. I knew this, and therefore I asked you what is the best management option. Pseudocyst, as I told you, it is a non-problematic condition. It usually is self-resolving. It is usually self-resolving. It resolves after 6 weeks. Yaad rakhna. It resolves usually within a period of 6 weeks. Okay, it resolves within a period of 6 weeks. Yaad rakhna. It is self-resolving. Okay, you don't need to do anything for the patient. Okay, if the patient presents to you within 6 weeks, you don't need to do anything for the patient. It is a self-resolving condition, and it will undergo spontaneous resolution. It will undergo spontaneous resolution. But if it does not resolve even after 6 weeks, if it does not resolve even after 6 weeks, yeah, if it is causing pressure symptoms in the patient, or if it is causing any other symptoms usually in the patient, pain vagara, then definitely that is the condition when you need to treat the pancreatic cyst. Okay, pancreatic pseudocyst rather. External drainage can be done, and external drainage is done with a catheter known as pigtail catheter. External drainage is done with a catheter known as pigtail catheter, or internal drainage procedure can be done. And this internal drainage procedure, now you are right, definitely it can be either a cystogastrostomy. Okay, you can open up the cyst into the stomach. That is what is a cystogastrostomy, or you can perform a cystoenterostomy. Okay, so it can be either a cystoduodenostomy or a cystojejunostomy. Therefore, I have written it as cystoenterostomy. Okay, so please remember, within 6 weeks, it will undergo spontaneous resolution. If it does not undergo spontaneous resolution, then you can perform an external drainage either with the help of a pigtail catheter or internal drainage procedures like cystogastrostomy or a cystoenterostomy. No issues with this. Yaad rakhna. Now, if I talk about pancreatic cancer, guys. So pancreatic cancer can be either at the head of the pancreas or at the periampullary junction. So what do I mean by the periampullary junction? So if, for example, these are your pancreas, samajh lo, theek hai, this is your duodenum, and at this junction, if there is cancer, okay, usually in the duodenum or at the ampulla. So I hope all of you are quite aware that the main pancreatic duct opens into the second part of the duodenum via a space which is called as the ampulla of Vater. Okay, the space where the main pancreatic duct opens into the second part of duodenum is called as ampulla of Vater. So at this position, if there is cancer, that is what is called as a periampullary cancer. Okay, so within 2 centimeters of this ampulla of Vater, if there is any cancer, it is termed as periampullary cancer. So it is important to differentiate whether the cancer is in the head of the pancreas or in the periampullary region. So how to differentiate? You can differentiate based on the jaundice. Definitely it will obstruct the bile duct also, and that will cause jaundice in this patient. Carcinoma head of pancreas causes which type of jaundice? Anybody? Carcinoma head of pancreas will cause jaundice in the late phase, and it would be progressive in nature, So please remember, carcinoma head of pancreas causes a late progressive jaundice. Carcinoma head of pancreas causes a late progressive jaundice, but periampullary cancer will cause a early intermittent jaundice. Okay, periampullary cancer will cause a early intermittent jaundice. आता जाता रहेगा. That means there would be a waxing and a waning course of this jaundice. ठीक है? So late progressive jaundice is seen in carcinoma head of pancreas, but early intermittent jaundice is seen in cases of periampullary cancer. Pain usually in cancer head of pancreas, it is a constant pain. Okay, in cases of carcinoma head of pancreas, there would be a constant pain, but in cases of periampullary cancer, there would be a intermittent pain or colicky pain, you can call it. Better term to be used is a colicky pain. ठीक है? In cases of periampullary cancer, there would be a colicky pain. Okay, there would be a colicky pain which is seen. Investigation of no, it's fine. ठीक है. So investigation of choice for carcinoma head of pancreas is usually a CECT abdomen, whereas for periampullary carcinoma it is a ERCP. For periampullary carcinoma it is a ERCP. For periampullary carcinoma it is a ERCP. ठीक है, याद रखना. Treatment of choice is what for carcinoma head of pancreas? The treatment of choice for carcinoma head of pancreas would be the treatment of choice for carcinoma head of pancreas. जल्दी से. This procedure came, this image came in the examination and they asked you what is this image called as. This image came in the examination and they asked you what is this image called as. Jaldi say. Very good. It is known as the Whipple's procedure. It is known as the Whipple's procedure. Please remember, if the head of pancreas is involved, definitely we need to remove the head as well as the adjacent structures, because pancreatic cancer, it can spread directly to the adjacent structures also very rapidly, and therefore we also need to remove the duodenum as well. We need to remove the gallbladder as well. Okay, we also remove some part of the jejunum. We also remove the head on the neck of the pancreas. Okay, we also remove the bile duct. So all of this is removed together, and if all of this is removed and we perform a hepaticojejunostomy, okay, hepaticojejunostomy, we perform a pancreaticojejunostomy, okay, and a gastrojejunostomy. याद रखना क्या क्या करेंगे? Hepaticojejunostomy, pancreaticojejunostomy, and a gastrojejunostomy. Then that is what is called as a Whipple's procedure. That is what is called as a Whipple's procedure. ये image आ चुकी है. They gave you this image. So please remember, this is the Whipple's operation or the Whipple's surgery. Offline जल्दी कर देंगे. Next session offline नहीं करेंगे. ठीक है?